as you improve the offering of the endeavor. And I remember when the original Medicare Advantage plans were coming out, there was this whole concept that there was the star ratings and ways of grading, and you had to iron out some of the details of how that would work out, and that iron is still out. Hasn't come back yet. As we continue to struggle with how you can actually quantify the quality of an experience for the beneficiary, the experience for clinicians and other providers, the services offered by an MA plan. And if you look into the nitty-gritty of what's really holding us back, I do think some of the things that we've mandated in order to provide quality control have actually gotten in the way. And there's some opportunities that I think that we can take advantage of just by the nature that in 2025 we have technologies that did not exist a decade or longer ago. But we are at an inflection point. Many of you, I suspect, are seeing this. Today is the first day of open enrollment, which I was telling Mary Beth is the reason we organized this conference on this exact day. And there's a lot of beneficiaries out there now looking around, trying to find out where MA plays a role in their life. Should they stay in traditional Medicare, what are the advantages, all the things you know quite well. But it sometimes gets drowned out in cacophony of all the talking around Medicare Advantage. What are the things that it actually offers us that are unique and valuable? And I think can be beneficial to focus on some of those. But at the same time, we're a bit of a dysfunctional family. I was driving over here and I told my much younger staffers that it's sometimes like Peyton Place. How many of you remember Peyton Place? They'd never heard of it. This gives you an idea. Then I tried Gunsmoke, no idea. Marcus Welby, MD, never heard of it. Maybe at that time, maybe the Kardashians are a better metaphor for what we're going through. But whatever it is, in any family, when you have people who are aligned in their desire and their interest area, as we all are by definition, because we're in this room, we care about healthcare. And for that reason, we care about people who need healthcare. You're going to have battles. You're going to have struggles. There are going to be times when you don't agree on how best to deliver what you believe is the best service possible or the most affordable service possible. And all parts of the industry right now are seeing themselves caught up in this in different ways. And they're touching the elephant from different perspectives. And if we can focus on the needs of the beneficiaries, because I am convinced more than ever, and obviously I have this bias because I'm a clinician, but we see it at CMS as well. The number one way that you reduce costs in healthcare is providing better quality. Because if you provide bad quality care, you're paying for someone to do wrong. They're usually not the cheapest in the business, by the way. They have outsized ego about their caliber and quality, but their pricing as well. Then you have to pay someone who's good to fix the problem, the person who did it wrong the first time. Then you got to pay for the complications downstream. So we want to reward insurers for providing ideal care, optimal care, but we don't want to have it cost more than fee-for-service Medicare. I believe those two goals sync well. There's tons of evidence about the caliber and the quality of Medicare Advantage. Most of you know I've written on these topics. So like many Republicans, I have a desire to see private sector solutions because I have confidence they'll often be nimble and creative and come up with ideas that are worth hearing and worthy of supporting. But the goal I just set, highest quality out there for the price that we pay for fee-for-service, I think is achievable. And if we reward insurers who are able to improve outcomes at the price that fee-for-service Medicare is currently paying, I think there's opportunities, there's a window there of places and outcomes that folks can take advantage of who are sitting in this room. And that's why I came to visit with you. Now, I want to pivot a little bit and talk about what I think MA plans could be focusing on. Excuse me. And I think you all recognize that MA is still, I think, is in its infancy. And we all saw it grow and birthed and couldn't walk, and then started to be a toddler and began ambling around. Now it's 54% roughly of total Medicare beneficiary volume. So now it's it's adolescent anyway. It's walking, but can it run? Can it fly? Are there things MA can do that go beyond anything we would ever have imagined possible for fee-for-service Medicare when it was created 60 years ago this year? And when Lyndon Johnson signed that act, Social Security Act, and bring it into fruition, the first patient was Harry Truman, because he wanted to launch a similar program during his presidency. He had to wait 15 years, but eventually he got to be patient number one. And I, by the way, got my beneficiary card this year. You should know that. So now I get to enjoy the meals that we're making in Medicare. But the opportunities we have if we do this correctly are massive. Because I see Medicare Advantage as the essential lever arm. This tool that we can use for good and sometimes not. But if we use it correctly and nimbly, we can do all kinds of things to refine and improve the system. So I thought I'd take a step back and just articulate what I think those problems are that we need to address. The first basic category are the rule of threes. What are the threes? Well, healthcare expenses are growing 3% faster than the economy. Might even be more this year. The number 3 cause of death in America are medical errors. And our life expectancy now is 3, maybe 4 years shorter than that of Europe. So we have objective metrics where we should be able to do better. Now, how does Medicare Advantage help? Well, MA is uniquely able to deal with the whole category of prevention. Let's just call it the MAHA movement for now, but it has a much bigger, much older heritage. People just are arguing that we should make it easy to be healthy in America. And moms today are definitely of the belief that it's hard to raise kids in America to be as healthy as it was for their parents. Now, we all see our parents as having idyllic lives and never having the challenges that we face. That's natural in the cycle of life. But it does seem objectively to be true that kids are prone to more problems today. Certainly categories of illness like obesity, which were uncommon 25, 30 years ago in kids, have grown. But in adults, they've dramatically increased as well. 43% of American adults now would be categorized as obese. Well, that's twice the number in Europe. Part of the reason we cost twice as much as Europe. We're 10 times more expensive than Japan, by the way. Sorry, not expensive, 10 times heavier than Japan on average in terms of obesity percentages. So there's things that we should be doing better. And that whole prevention category is a place that MA is uniquely able to use that lever arm to nudge people in the right direction. But then you also have the reality that people are going to get sick sometimes. Yes, chronic illnesses increase the incidence of that. Obesity leads to hypertension, diabetes, cognitive dysfunction, myocardial infarctions, kidney failure, a whole slew of things. But in addition, you have genetic dispositions to these problems, so you're going to have chronic illnesses. And how we deal with chronic illnesses has been a major focus for the last 10 years of the healthcare economy in this country. And we really haven't done as much as we could do improving the care of folks, for example, with metabolic syndrome. We have unique opportunities to do that, and you have, again, a lever arm that's able to push these patients, these beneficiaries, in ways that other systems have not evolved to be able to do, certainly not your scale. And then finally, we have end-of-life issues. Another very delicate area to talk about, a topic that has generally been left behind because folks don't even know how to engage it, and it is a more complicated category of issues to address. But again, MA has opportunities to play a role there. Now, one of those lever arms that you currently are using is prior authorization. It's an example of something that folks have been upset about. You all know about it. And the sensitivities around prior authorization and what it is able to do, and is quite effective, as you all know, in addressing wrongful procedures and inappropriate expenses. But it has been used at times in ways that are very confusing for the American public and maddening, in part because you're in the middle of this precious relationship covenant you have with your doctor. And right smack in the middle of that, the long arm of insurance companies comes in and pulls away your belief that the doctor gets to decide what tests you have to figure out if that thing on your skin is a mole, that's benign, or a cancer. And now all of a sudden you're waiting for weeks in anxiety trying to figure out what to do. And we have better ways of doing that. And you saw earlier this year, in our administration, did something that we believe is emblematic of our desire, working with industry, which is to acknowledge that we have legal opportunities through Congress, statutory ones. We have regulatory powers to obviously play a role in how things are done. But maybe, if you want to be fast and effective and more nimble, you'll use industry and have them do it. Recognizing we're here watching and we have the ability to take action when necessary, but if we can get industry to play an active role in figuring out a better way of doing prior authorization, if industry can figure out what metrics of success might look like that are agreeable and achievable, if industry knows where the problems are better than anyone else does, which I think is the case usually, maybe industry can come up with a selection of ideas that will be more effective. And in the case of prior authorization, we've, I believe, been able to thread that needle. We know better now that there are procedures that probably don't need to be prior auth, doesn't help that much. We believe there's ways of adjudicating whether a procedure should happen or not, or medication be given. That can be done the way banks decide if debit cards are appropriate to be used to buy a cup of coffee. But essentially, if you can't use your debit card knowing that you have money in your bank to buy a cup of coffee, you're going to stop using the debit card. And that's sort of the promise here. And the urgency. Americans should know that if my insurance, for whatever reason, doesn't cover this procedure, or if this procedure should not happen to me for any reason, no matter what my insurance is, and Prior Auth is designed to achieve those goals, to help me understand the problems that we might be encountering, I should know that quickly. In fact, I should know it in the moment. And that's one of the goals that industry has agreed to, and by the end of next year, is to make this real-time experiences, because I'm much better off as a physician dealing with the Prior Auth concern if I hear about it as soon as I'm making the recommendation, than if I'm battling with papers going back and forth for weeks thereafter. And of course, industry then brought other ideas to us. Gold carding, where you reward clinicians for doing a great job all the time. They don't have to bother going through the whole hassle anymore. In fact, that incentivizes clinicians who are not gold card to become gold card by doing things that might be effective. I did not even realize that there were hospital systems that have no prior authorization because they're joined with their payers and they have other ways of ensuring quality. And so when you begin to uncover a lot of these opportunities, you begin to think, well, geez, I could pass a law and lobby Congress to do that and push for changes at that level, but that's not the nimble, flexible approach that might work best for the American people. And that's, I think, one of the goals we have, is to raise the bar. If we're working with industry, and I'm here today because we're open for business and we want to hear your ideas. But if we're open and desirous of hearing your ideas, give them to us. But then also take action on your own when possible. We'll give you safe harbor, we'll support you, we'll do things that are necessary to make it easier for you to do the right thing. And I know in every organization, you've got people who are trying to do things that we believe are more aligned with what's best for the American people. And there's some folks who may not have that same priority list. We want to support the folks that believe in the things we believe in to at least be heard more widely, more loudly in those organizations. And by doing that, provide the accountability and the transparency that we believe benefit the American people and the American taxpayer. So if we're going to restore trust in MA, and if we're going to do it together, and get MA to be able to not just walk, run, and fly out and while delivering therapies and options that we never thought even possible before to benefit their beneficiaries, what's CMS going to do? Well, our goal, and we have OKRs, objectives and key results on these topics, is to be the best payer of all. So to actually be number one, if we can, in the things I'm talking about, so we can lead by example, but then support others who want to do the same thing, because we can't do it ourselves. Because you are the payer for more than half the beneficiaries of Medicare, so if we're going to be number one, you have to be number one. There's a category. We want to make sure you're syncing with CMS and aligning with us on these issues. So for example, if we're going to take a big initiative on fraud, waste, and abuse, which we are, we're going to crush the fraud, waste, and abuse. Work with us. Be our early warning system. Tell us about problems you're witnessing. Help us figure out better ways of addressing it. I've come to the conclusion, for example, in fraud, waste, and abuse, that we're spending too much time chasing criminals trying to put them in jail, when the real problem is the money leaving the building. And I also feel that way because if you do get caught stealing $5 million from Medicare, you go to jail for 18 months. It just doesn't match. If you robbed the bank for $5 million, you wouldn't have an 18-month jail sentence. That's a good trade-off for a lot of people. And so we don't want that to be our main goal. I'm not going to judge our administration's success at CMS by how many people go to jail. We're going to judge by how much money we have not sent out the door. And I'll announce today that we have prevented $3 billion just since we came into office from leaving. You have sound effects and everything. How about they've won? So $3 billion doesn't leave the room. I don't know how many criminals could have gone to jail, but we did a big bust with the DOJ and the OIG and great people working hard for a long time on a multinational criminal organization, which I'll share with you is based in Russia. And people didn't go to jail because they'd already escaped back to Russia. And so if we had more DME, the suppliers in South Florida than McDonald's, maybe we have a strategy issue here, not just a problem. So we're working with Treasury and others, trying to figure out better ways of doing detection of banking fraud. Because oftentimes it's not even just that they're stealing money from Medicaid, and Medicare, which is a massive target, but as they put the harpoon into us, they also money launder. So there's other opportunities for us to make America a better place just by using the tools that we have within healthcare to identify fraud. But most importantly, and then I'd love to open it up, most importantly, we want to empower the beneficiaries. Give people tools to help themselves. They're incentivized. It's their bodies. You know that in your own families. What can we do to allow folks more insight into the care they're getting insights based on their medical records that we can now use third-party apps if they permit us. It's their medical records. They own them. They paid for them. Through us, but it's theirs. So how do we get them to use those records to get better advice, to customize to their own habits, their foibles? There's sometimes the day you don't want to message a person. They're not so good in the morning. Tell them to stuff in the afternoon. Maybe they want to hear from different doctors. How do you connect those people together? What are the rewards you can put into the system to make it worth their time to pay attention? These are all things MA is uniquely able to do in ways that other endeavors have been more challenged by, which we'd like you to continue to explore. And we also believe that if you're able to empower the beneficiaries by at the same time incentivizing providers to do the things we're talking about with the beneficiaries, it's a self-fulfilling and positive virtuous cycle, because it'll build confidence that I'm being informed as a doctor about ideas that would benefit my patient, and while I'm being informed, I can share that wisdom with you as well. It builds the belt and suspenders into the system that makes us all feel better. It also deals with a crisis that I feel coming to healthcare in America, which is we've taken some of the fun out of practicing medicine. And the loss of mojo amongst the clinicians that I talk to is not because they're working hard. We've all worked hard. Those of you who practice medicine or nursing or in the healthcare profession, but if you're working your tail off to save someone's life, it's very different than working your tail off to fill out paperwork to get the prior auth done. And when we're spending as clinicians 12 hours a week doing paperwork, and we know you're spending the same amount of time and money probably as we are to do the same thing, that's 12% overhead that doesn't benefit the American people, our patients, or make our lives any better. We should be better than that. And I came here to make sure that you understand it's our desire to work closely with MA plans across the board and their supporters, but also folks who feel that we can do better, because all of us are in the same boat here. One of the beautiful things about having a ton of promise is that you have a ton of promise. And we expect you to deliver on it, because we know there's a lot more out there, a lot more juice to be squeezed. So thank you very much.